Peptic ulcer disease is a break in the inner lining of the stomach, the first part of the small intestine, or sometimes the lower esophagus. An ulcer in the stomach is called a gastric ulcer, while one in the first part of the intestines is a duodenal ulcer. The most common symptoms of a duodenal ulcer are waking at night with upper abdominal pain and upper abdominal pain that improves with eating. With a gastric ulcer, the pain may worsen with eating. The pain is often described as a burning or dull ache. Other symptoms include belching, vomiting, weight loss, or poor appetite. About a third of older people with peptic ulcers have no symptoms. Complications may include bleeding, perforation, and blockage of the stomach. Bleeding occurs in as many as 15% of cases. Common causes include infection with Helicobacter pylori and non-steroidal anti-inflammatory drugs, NSAIDs. Other less common causes include tobacco smoking, stress as a result of other serious health conditions, Behçet's disease, Zollinger-Ellison syndrome, Crohn's disease, signs and symptoms of a peptic ulcer abdominal pain, classically epigastric, strongly correlated with meal times. In case of duodenal ulcers, the pain appears about 3 hours after taking a meal and wakes the person from sleep. Bloating and abdominal fullness, water brash, a rush of saliva after an episode of regurgitation to dilute the acid in esophagus, although this is more associated with gastroesophageal reflux disease, nausea and copious vomiting, loss of appetite and weight loss in gastric ulcer, weight gain in duodenal ulcer, as the pain is relieved by eating, hematemesis, vomiting of blood. This can occur due to bleeding directly from a gastric ulcer or from damage to the esophagus from severe continuing vomiting. Melena, tarry, foul-smelling feces due to presence of oxidized iron from hemoglobin. The timing of symptoms in relation to the meal may differentiate between gastric and duodenal ulcers. A gastric ulcer would give epigastric pain during the meal, associated with nausea and vomiting, as gastric acid production is increased as food enters the stomach. Pain in duodenal ulcers would be aggravated by hunger and relieved by a meal, and is associated with night pain. Complications. Gastrointestinal bleeding is the most common complication. Sudden large bleeding can be life-threatening. It is associated with 5% to 10% death rate. Perforation, a hole in the wall of the gastrointestinal tract following a gastric ulcer, often leads to catastrophic consequences if left untreated. Erosion of the gastrointestinal wall by the ulcer leads to spillage of the stomach or intestinal contents into the abdominal cavity, leading to an acute chemical peritonitis. The first sign is often sudden intense abdominal pain. Gastric outlet obstruction, stenosis, is a narrowing of the pyloric canal by scarring and swelling of the gastric antrum and duodenum due to peptic ulcers. The person often presents with severe vomiting. Cancer is included in the differential diagnosis, Helicobacter pylori, as the etiological factor, making it 3 to 6 times more likely to develop stomach cancer from the ulcer. The risk for developing gastrointestinal cancer also appears to be slightly higher with gastric ulcers. Causes. Helicobacter pylori is one of the major causative factors of peptic ulcer disease. It secretes urease to create an alkaline environment which is suitable for its survival. NSAIDs. Taking non-steroidal anti-inflammatory drugs, NSAIDs, such as aspirin, can increase the risk of peptic ulcer disease by 4 times compared to non-users. The risk of getting a peptic ulcer is 2 times for aspirin users. Risk of bleeding increases if NSAIDs are combined with selective serotonin reuptake inhibitor, corticosteroids. Stress, physiological, not psychological stress due to serious health problems, such as those requiring treatment in an intensive care unit, is well described as a cause of peptic ulcers, which are also known as stress ulcers. Diet. Dietary factors such as spice consumption were hypothesized to cause ulcers until the late 20th century, but have been shown to be of relatively minor importance. Caffeine and coffee, also commonly thought to cause or exacerbate ulcers, appear to have little effect. Diagnostic test: endoscopies, barium contrast X-rays, esophagogastroduodenoscopy, also known as gastroscopy, blood test, urea breath test for Helicobacter pylori rapid urine test, differential diagnosis, gastritis, stomach cancer, gastroesophageal reflux disease, pancreatitis, hepatic congestion, cholecystitis, biliary colic, referred pain, pleurisy, pericarditis. Treatment and management. Once the diagnosis of H. pylori is confirmed, the first-line treatment would be a triple regimen in which pantoprazole and clarithromycin are combined with either amoxicillin or metronidazole. This treatment regimen can be given for 7-14 days. For those with bleeding peptic ulcers, fluid replacement with crystalloids is sometimes given to maintain volume in the blood vessels. Maintaining hemoglobin at greater than 7 GDL, 70 GL, through restrictive blood transfusion has been associated with reduced rate of death. NSAID-associated ulcers heal in 6 to 8 weeks, provided the NSAIDs are withdrawn with the introduction of proton pump inhibitors, PPI. H2 receptor antagonists. Like PPIs, H2 receptor antagonists work by reducing the amount of acid your stomach produces. H2 receptor antagonists, such as famotidine, are often used to treat stomach ulcers.